Shall we start? Okay. First, I want to thank CERM and the City of Hope for providing me with this opportunity to share what I have learned on neurological disorder, the CAR-T therapy treatment for neurological and autoimmune disease. The content I presented today is different from yesterday's modules, which you can apply immediately to the bedside nursing. The content a little dry today. I will do my best and try not to lose you in the next 20 minutes. CAR-T cell therapy has played a crucial role in the treatment for neurological disease. CAR-T therapy has played a crucial role in the treatment of neurological disorders and autoimmune disease. So for neurological cancers such as glioblastoma, ependymoma, megaloblastoma, due to the ability of crossing blood-brain barrier and using diverse targets. CAR-T therapy for the treatment of neurological disorders such as multiple sclerosis, myasthenia gravis, and inflammatory myopathy are all under the investigation for potential treatment options. So CAR-T cell therapy for the treatment of pediatric high-grade glioma with H3K27M mutation altered, the GD2 CAR-T cell therapy could clear most of majority of cancer cells in the preclinical mice models. Ependymoma constitute roughly about 8 to 10% of pediatric brain tumors versus less than 4% in the adult nervous system tumors. Megaloblastoma is the most common malignant pediatric brain tumors. The incidence rate roughly about 6 per million in 1 to 9 years old patients. According to SHEAR database, the incidence rate is in pediatric 6 versus 0.6 in adults. Glioblastoma, WHO grade 4, is the most malignant and aggressive brain tumors. So currently, with the population incidence rate about 10 over 100,000. Current treatment options, including the surgery, followed by the chemotherapy and the radiation therapy, still with the median survival rate roughly a little over a year. EGFR-V3, IL-13 receptor alpha 2, and HER2 were used to treat glioma cases in the published clinical trials, and they have been clinically confirmed safe and efficient. This diagram outlined the fundamental of CAR-T cell therapy for neurological disease. CAR-T cell recognize the surface antigen of glioblastomas, and once the GBM antigen is recognized, the T cell activated and multiply, and the cancer cell is destroyed, and the cytokine is released. There are about 40% of newly diagnosed glioblastoma with EGFR gene amplifications. EGFR-V3 targeted CAR-T cell therapy have shown effective tumor controls. However, a major limitation of EGFR-V3 as a target antigen is that heterogeneous expression in the glioma brain tumor tissues, which may lead to the generation of variants, escape variants, which could be resistant to CAR-T cell therapy. IL-13 receptor alpha 2 is a cytokine released by T helper cells to regulate inflammation and immune response. It is expressed in the majority of adult and pediatric brain tumors, but not expressed at a significant level of the normal brain tissues. So CAR T cell therapy has shown that the treatment is feasible with the encouraging clinical response in the preclinical mice model. Actually, in the first human pilot study, sorry. HER2 is epidermal growth factor, which is expressed in normal epidermal cells. It is overexpressed roughly about 80% of GBM tumors. HER2 has expression in various normal tissues as well. So this may lead to, especially HER2 expressed in some vital organs. So it may lead to the fatal toxicities. Ongoing CAR T cell-based clinical trial to glioblastoma. B7H3 target expressed in the tumor-associated vessel and fibroblast. So which suggests that this target CAR T cell may eliminate tumor cancer cells not only through the direct target, and also may through the other means, such as the angiogenesis inhibition. So this target also showed a significant tumor control in the mice model. CD147, it has a high expression in the glioma rather than the normal brain tissue. An open-label phase 1 clinical trial has started to recruit patients with recurrent glioblastoma to test the efficacy, safety, and tolerance. GG2 specific CAR T cell have initiated clinical trial also and targeting high-grade glioma, which include glioblastoma. MMP2, this target is selectively binding to the primary brain tumor tissue and rarely binding to the normal brain tissue. So a phase 1 CAR T cell study of the treatment of MMP2 positive for the recurrent and progressive GBM has been initiated and start to recruit patients. NKG2D ligands study has shown that treatment with chemotherapy and radiation therapy can upregulate NKG2D ligands expression on GBM cells. So this indicates that the potential of combination therapeutic strategies. Study has shown that NKG2D in combination with radiotherapy significantly prolonged the progression-free survival overall in mice with intracranial engrafted glioma cells. These are pre-clinical CAR T cell therapy for gliomas could be the potential treatment options. The challenges of CAR T cell therapy to gliomas. There are several limitations could decrease the effectiveness of CAR T cell therapy in treating glioblastomas, including the tumor heterogeneity and local physical barriers and antigen escape. These all makes choosing the cancer antigen of CAR extremely difficult. The other factor is the blood-brain barrier. Studies have shown that the blood-brain barrier still can be intact in spite of the high tumor burden of glioblastoma. Therefore, the mode of delivery of CAR T cell therapy to treat glioblastoma should be reevaluated, such as intracavity, intratumoral injections, and intracerebral intraventricular injections to the tumor site. The study have shown that local regional injection of CAR T cells has improved the CAR T cell infiltration into the tumor site and increased the tumor control in several preclinical studies. strategies to enhance the CAR-T-based immunotherapy against the glioblastoma. For example, one strategy to overcome the escape mechanism is that a CAR-T cell can target on multiple target antigen at the same time. For example, CAR-T cells specific to both CD70 and B7H3 have shown the effective tumor control in the preclinical mice model. The other study showed the chemotherapeutic agent and radiotherapy may sensitize the cancer cell to elimination by CAR-T cell through several mechanisms. Radiation therapy can induce the changes in the tumor microenvironment and may help boost the CAR-T cell activities. And therefore, it increased the permeability of blood-brain barriers. The other most promising combination therapy strategy is the synergistic application of CAR-T cell with the immune checkpoint blockade, such as PDL, PDL1, and they have shown that increased activity of CAR-T cell in the preclinical mice model. The current standard treatment for medulloblastoma is the surgery, chemotherapy, and craniospinal radiation. HER2 expression can be estimated roughly about 40% of medulloblastoma, but there is no expression in the normal brain tissues. So this is likely an ideal target antigen for CAR-T cell therapy for medulloblastoma. Study also revealed that targeting B7H3 could be a potential treatment option for medulloblastoma. Clinical study has shown that the three surface antigen, EphA2, HER2, and interleukin-13 receptor alpha-2, they are all expressed on medulloblastoma and ependymoma, but not expressed in normal developing brain. So the intrathecal delivery alone or combined with azacitidine showed effective therapy for medulloblastoma. I want to mention some cellular immunotherapy for medulloblastoma. The phase 1 clinical trial of intracranial NK therapy for medulloblastoma have shown the treatment is feasible and safe. And phase 2 DC therapy also showed a significant tumor control for 12 months. There are multiple NKT cell phase 1 clinical study. They are testing the safety and dosing of CAR-T cell therapy in medulloblastoma patients. So I put this table here. It shows different cellular immunotherapies advantages and disadvantages. CAR-T therapy for multiple sclerosis. Multiple sclerosis is a CNS autoimmune demyelinating disease. Currently, CAR-Tregs have shown that it is a good potential treatment option for MS. CAR-Tregs technique was able to prevent MS patients for relapse and also stop their further progression from worsening. So these are encouraged findings. Myasthenia gravis is another autoimmune disorder caused by the failure of neuromuscular transmission at the neuromuscular junction. So there is a MG001 prospective multi-center open label phase 1b/2a study of this CAR-T08. It is an autologous anti-BCMA CAR-T therapy in adults with generalized myasthenia gravis. There were a total of 14 participants, 10 women and 4 men. There was no dose-limiting toxicities, no CRS, and no neurotoxicities. The common adverse events was headache, nausea, vomiting, and fever. The fever is also not associated with the CRS markers. And those symptoms were also resolved within 24 hours after the infusion. In this 1B study, the participant had showed a meaningful decrease in myasthenia gravis severity scales up to 9 months. So there is a phase 2A clinical trial of this Descartes 08. It was given outpatient treatment without lymph depletion. There were 7 participants who received 6 weekly infusion of CAR T cells. They all had a significantly clinical improvement. 5 out of the 7 participants even maintained the improvement at month 12. So this is a refractory myasthenia gravis case. A 33-year-old woman who was diagnosed with anti-acetylcholine positive generalized myasthenia gravis in 2012. From November 2021 to May 2023, she has experienced 5 times myasthenia gravis crisis leading to the ICU admission with invasive intubation. She has tried surgery in the past, rituximab, Cellcept, and Velcade before the CAR T cell treatment. The patient's ongoing immunosuppressant was tapered down to low-dose glucocorticoids before the leukapheresis and CAR T cell infusion. Cellcept was resumed after successful collection. Up to 2 days before the start of lymph depletion with fludarabine and Cytoxan. And the patient had no adverse event related to the CAR T cell infusion, except she only had grade 1 self-limiting resolving transaminitis. This is the first case of successful treatment of patient with severe refractory anti-cholinergic positive generalized myasthenia gravis with fully human autologous anti-CD19 CAR T cells. There was about 70% reduction in the anti-cholinergic positive antibodies. It was dropped from 2,400 at day 0 down to 700 at day 62. CAR T cell therapy against autoimmune disease. Given the high cost of CAR T cell manufacturing for the autoimmune disease, so initially it could be applied or available only for the severe form of autoimmune disease patients. However, CAR T cell therapy allows the discontinuation of immunosuppressants. So from this point, the cost could actually reach the break-even in a couple of years, since the cellular immunotherapy holds the promise for long-term control of the disease. The feasibility of CAR T cell treatment for autoimmune disease strongly depending on the multidisciplinary team coordinations, including multi-specialties, hematologist, rheumatologist, neurologist, and immunologist. The best procedure for CAR T cell treatment for autoimmune disease is still unknown, but CD19 is a promising target to treat autoimmune disease. According to the study, CD38 and BCMA antigen also could be a potential treatment option for autoimmune disease. There are a lot of excellent talks yesterday from module 1 to module 3 on CRS and neurotoxicities. I will move to the next slide. So currently at UC Irvine, we have 3 active CAR T-cell treatment for neurological disorders and autoimmune disease, and 2 pending start in the early May. We also have 6 CAR T-cell treatment pending for neurological and autoimmune disease pending to start. So currently UC Irvine Alpha Clinic, we have 60 clinical trials for 20+ disease indications. And thank you very much for your time.